Wow, what a lineup. It is an absolute honor to be here today and to get a chance to talk a little bit about something that I'm very passionate about. As Yale said, I was a hospice social worker for 10 years, and it's amazing to see these conversations happening, and I'm ready for the culture change that we've been talking about. I would love to see what we've been practicing out in the field implemented in a sustainable way across the country. So not to insult your intelligence, but I wanted to start with a general overview of palliative care. And this isn't all that new, but for me, hospice is palliative care. It's patient and family-centered, interdisciplinary. It focuses on quality of life. And there is hospice, which is palliative care, and non-hospice palliative care. And I wanted to start with this graphic because it shows where social work is situated within palliative care. The outer concentric circle here shows how the interdisciplinary team addresses the multidimensional needs of the patient and the family. When you start to break down this model, if you don't have the family there, then it is no longer palliative care. If you don't have a true interdisciplinary team addressing the multidimensional needs, it is not palliative care. Now, the different disciplines, we bring unique perspectives, unique skill sets to the table, but there is a ton of role overlap. I see social work as, actually I see the palliative care team as kind of a Swiss Army knife, and I think of social work as the can opener on the Swiss Army knife because we get people to open up. So palliative care is a better model of care for what we know when it comes to people's health needs. This pie chart here shows a population-based perspective on health, and Tom Smith earlier today, I believe was talking, no, it was Bob Arnold who was talking about the overemphasis we have on medical care, on health care. And looking at the pie chart, healthcare is just a small slice of the larger pie. And palliative care ideally addresses the larger pie. So not just that 20%, but focusing on the physical environment, the ambiance that the patients and family members are dealing with, the socioeconomic factors, which includes health literacy and health behaviors, not just medical care. In fact, I view medical care a lot like water for a plant. It's important, it's good, but too much can be a bad thing. So the role of social work within palliative care, we generally attend to many of the non-medical aspects related to care. That being the social, the emotional, the behavioral, and the environmental. This includes a comprehensive psychosocial assessment. We help family members and patients navigate complex healthcare systems and negotiate those transitions across care settings. We help foster coping and minimize psychosocial distress. We provide emotional support. We facilitate decision-making. Quite often we are leading family meetings. We're coordinating these family discussions about goals of care. I think there's this belief that social workers aren't conducting these family meetings, but we are, and the evidence supports it. We're working to improve access to care, better adherence to treatments when they're prescribed, and we're connecting families to needed resources, often resources that are available in the larger community. So what I'd like to discuss are 5 points that I see as intersecting when we look at health literacy, palliative care, and social work. And the first is careful attention to language, addressing myths and misperceptions. A lot of what I'm talking about today has already been discussed, so at this point, I'm just telling you what you've already heard and maybe putting an exclamation point at the end. Advocacy for social justice and vulnerable populations, facilitating coping and minimizing distress, which is related to health literacy, and acknowledging uncertainty and change. And this will sound familiar because in some respects we're talking about that emergent health literacy, the fact that it evolves and changes over time. This is the standard definition that we've used all day long. It's important to note that at the end, we are trying to facilitate decision making. That is the goal here. Services needed to make appropriate health decisions. And it's an uphill battle. The last nationwide study that looked at adult literacy found that roughly a fifth, just over a fifth of adults in the US have trouble reading and synthesizing basic information. Not medical information, not medical acronyms, not Latin phrases, not drug names, basic information. So in schools of social work across the country, we focus on communication and family dynamics, and part of that is careful attention to language. Hans-Georg Gadamer, who's a philosopher, said, "Sein, das verstanden werden kann, ich spreche," and that means language that can be understood. Language is that which can be understood. I've had 8 years of German, and that's about all I have to show for it. But what Gadamer is saying here is that language isn't just important, it is how we make sense of the world. The way you make meaning of life is a conversation that's going on in your head, an internal dialogue. And he suggests that there would be no reality without that conversation, without language. So language isn't just important, it is reality. So where do we fail? Where are the opportunities for failure and our potential missteps? Medical jargon. I remember my very first day attending a hospice team meeting. There was a nurse giving a report, and she was talking about a patient who was SOB. And I thought this nurse was insulting the patient. But no, she was saying short of breath. Patients don't get the acronyms, don't get the Latin phrases, terms, basic terms like oncologist sometimes don't make sense to our families. The volume of information. I know in hospice admissions now, I've observed many, both in my own practice and in my own research, and the information that we give families are 1 to 2 inches thick. We're handing them paperwork that is thick, and we just can't expect them to retain all that. They're dealing with some very difficult healthcare situations, healthcare decisions, emotions, and here we are handing them a ton of paperwork. It's not fair. A lack of time, and this goes for all clinicians. We can't sit there and unfortunately devote 4 or 5 hours to families that need 4 or 5 hours. Our time is limited. And so we need to figure out some way to manage our time, to work together as a team so that we can meet the family's needs. Sometimes metaphors, they may seem like they're wonderful, they're well-intended. But metaphors like a fight against cancer can put people in a position where they're fighting against themselves, kind of an intrapsychic dilemma. And then when they succumb to the illness, it's because what? They didn't fight hard enough. They lost the fight. There's subtle blaming going on there. There isn't a whole lot of evidence looking at this because it's hard to explore the impact of these metaphors that we use, but we certainly need to question our use of them. What do they mean to the people that we're communicating with? We need to avoid, in my opinion, absolute terms. Very rarely do absolute terms reflect reality. But we use absolute terms all the time. We talk about everything. We talk about nothing. We talk about all. And when we say things like, there's nothing more we can do, and really what we're saying is, it's time to talk to palliative care. It's time to talk to hospice. Then we are saying that hospice and palliative care are what? Nothing. And that is untrue. We also need to be very attuned to culturally specific terms. In my own research, the term good death, we use that quite a bit in the medical setting. But Hispanic individuals may not understand, or at least that may not be part of the Hispanic lexicon. Like I said, sometimes the conversation is framed as nothing can be done, but there is a lot we can do. Expert pain and symptom management, attention to quality of life and dignity, mobilizing social, emotional, and spiritual support, strengthening relationships, bringing in hospice and palliative care. It's also important to define the role of family caregivers, and they can help with decisions. They can often be the eyes and ears for the medical team, and we need to provide information about hands-on care, things like PICC lines. This is what I was referring to earlier. The concept of good death may not be meaningful across cultures. Hispanic respondents, this was a nationwide sample of cancer decedents, and we asked family members about the quality of their death, and Hispanic respondents were 17 times more likely to describe a death as bad rather than good. So, are we using the right terminology? We need to choose our words carefully because the way we frame decisions impacts how decisions are made. So it's important to recognize our own biases, our own perspectives, our own prejudices, so that when we go in there, we kind of understand our own frame of reference, and that we also understand that when we say, do you want someone to come in and jump on your chest? We may not be presenting that in a very fair way. Or if we ask a question and we're nodding our head, we might be prompting a yes answer, or shaking our head prompting a no answer. So we need to be very careful about the words we use and the nonverbal language. Wow, I am not going to get all this. Addressing myths and misperceptions. This came up earlier. We have to address the misinformation that's out there. There's a lot. Only 20 to 30% have heard the term palliative care. That's just the term. That's not asking them what it means. Just the term palliative care. So we throw that out, and to a lot of people, they're hearing it for the first time, or it's meaningless. Hospice is the more familiar model of palliative care. 80 to 85% have heard of hospice, but do they have a good understanding of what that means? No, not a great understanding. We did a survey across the country, and we asked people 23 items, true or false tests related to hospice, and they got a 78%, so a C+. Not great. And 2/3 did not know that hospice requires patients to forego curative treatment. 2/3. And according to the hospice Medicare benefit, that is a core, that's a defining characteristic of hospice. Here's some of the other myths. They're pretty common. Hospice is only for cancer. It's a place as opposed to a model of care that can come out to wherever you are. It's only for the patient, not also for the family. It's expensive. It's usually paid for by Medicare. Stops after 6 months. We know that there's a renewal period. And there are many more. So it's not just these. There's a ton. We need to address these misperceptions, including overblown beliefs about treatments and minimizing risks. We need to advocate for those who are being left out, so giving voice to the voiceless. Social workers work with hard-to-reach populations that may be compromised when it comes to health literacy. These are some. We're especially concerned about African Americans and Hispanic participation in hospice and palliative care and disparities that we've observed in pain management. It's also vital that we're addressing the emotional piece, that isn't neglected. And that's important because how we're coping with something impacts our ability to synthesize information. So it directly impacts health literacy. Things like shock, denial, anger, blame, anxiety, and depression, those affect our ability to understand information and make decisions based on that information. Acknowledging change and uncertainty. We have this sense that we have a lot of facts to disseminate, but the truth is we have a lot of unknowns, and we need to have frank conversations about what we don't know, and that health literacy, as well as preferences, change over time. These can change because of side effects, disease progression, or changes in our emotions, our ability to cope. Concluding thoughts, health literacy is invisible, so we need to be vigilant and assess for it. We need to start where the patient and family are. When it comes to health literacy, communication is key. It is impossible not to communicate. I'd like to hit that point again. It is impossible not to communicate, and so we need to pay attention to things like nonverbal cues. Empathy and expectations are vital. Involving families whenever possible, including in team meetings. Greater transparency regarding healthcare costs, that came up earlier. I think that is needed, greatly needed actually, and individual preferences are paramount. I think this should be the prime directive for palliative care. We sometimes overemphasize pain and symptom management, but I had a patient say, John, my pain is an 8. I know that I can take medication and relieve that pain, but I'm dying and the pain makes me feel alive. I want to stay in pain. So it's important that whatever metrics we come up with to measure the success of palliative care, that we are taking into account patient preferences. And I'd like to leave you with that and say thank you. It is a complete honor.